Wonderful. So I'm going a bit quickly today in terms that everybody knows this, right? Medical MCQ for all and what we provide. I myself, Dr. Munjal Pandya, a hemato-oncologist and bone marrow transplant with quite rich experience practicing more than 20 years and coaching 100,000 patients and quite good in hematology. This is Dr. Arti, is consultant pediatrician. Dr. Maddy is also internal physicians. Dr. Sonal is also emergency physicians. Dr. Akanksha recently joined. We supposed to do the joint mock test, but unfortunately she got viral, so could not join. Dr. Meghna is also based at UAE. She is taking care of our data flow. Dr. And we have these teams as well. You can see Dr. Pooja and Dr. Kainat and Pallavi. Everybody knows Pallavi. So this is our nice team of doctors. Last things like this is a medical MCQ for all. Excellent 170, close to 200 now videos are uploaded, right? So you can just, I mean, on mobile application, Android and iPhone, those who are using subscriber, they can download the mobile application and you can surf whole the website. And last but not the least, right? Try to do the maximum mock test every time. I'm reinforcing the same thing. Try to do the maximum mock test because without mock test, it's difficult to do the assessment, self-assessment, right? So before you go for the exam, you should have at least 5, 10, 15 good mock tests. So at least you know where are you standing, what are the mistakes, how we supposed to improve before going for the exam. So extremely important. And let me tell you one more things. Our YouTube channel, I already told you, right? So this is our YouTube channel as well, right? MCQ for all. So there are lots of videos uploaded on it. So same name and same logo. So just go and download it. I strongly recommend you see at least one video a day, right? That makes your job very easy. Or all conceptualized and many discounted packages are there. So you can later on inquire. So let's start with the first questions. I want everyone to interact and try to discuss, right? I'm not at all in hurry, just try to apply fullest of your knowledge what can be done for every patient. A 58-year-old man present with a sudden dyspnea, chest pain, and syncope. On arrival, blood pressure was 78 over 45. Heart rate is 128. Respiratory rate is 32. SpO2 is 84% on room air. ECG shows tachycardia. Beside echo shows RV dilatation and dysfunctions. What is the most appropriate immediate management of this patient? Low molecular weight heparin, CT pulmonary angiography, immediate systemic thrombolysis, oral direct oral coagulant drug, or infia vena cava. So think over it for 10-15 seconds. You need to practice, you need to be hurry up because in exam you won't may not get 1 minute to think. You have hardly 10-15 seconds, right? Otherwise, you cannot end up with your all 150 MCQ, especially for DHA. So, as I told you, this is the triad where you supposed to get the diagnosis. So, there is no diagnosis. There is no diagnosis. You have to think of some diagnosis in your mind, and then you need to jump on the treatment. They are directly asking for some kind of management, right? What is the immediate management? Right. So most of the things is investigation related and treatment related. CT pulmonary angiogram investigation, right? Infia vena cava kind little treatment, right? Rest of the things. So you want to investigate, you want to directly treat what you exactly want to do, right? So get the diagnosis. What is the diagnosis? Any volunteers can open up the mic, no problem. They can discuss. It's absolutely a learning platform, so don't worry about right or wrong. Yes, you start. Yes, what's the
Pulmonary,
diagnosis?
pulmonary embolism.
Wonderful. Pulmonary embolism. Fine. So, one diagnosis we got to know is pulmonary embolism. Now, sir, you tell me what is the most appropriate immediate management for this patient. Patient is in front of you, right? So, what is your treatment of choice?
Option A,
Option A, low molecular weight heparin. So, now tell me why you want to select option A. You don't want to go for CT pulmonary angiogram for confirmation. This is the clinical history, or you don't want to do the thrombolysis of this patient. And if yes, why? If no, why? Yeah, tell me. Yeah, this is what the learning is. Yeah.
the history present everything, so don't waste the time to diagnose.
Okay, fine. So you don't need to waste the time, right? So do you think low molecular heparin would be the good options for this unstable patient? By me, it's an unstable patient. For your kind knowledge, everybody listening me, anything less than 90 systolic blood pressure is unstable in any patient, right? Cardiac, head to toe, any condition or any emergency comes to your ER tomorrow. If you find that systolic blood pressure is less than 90, consider it is an unstable patient. So by all means, it is unstable patient. Blood pressure is 78, heart rate is too high, right? Heart rate is too high. Normal is 60 to 90. This is 128, right? Respiratory rate is around 1820, right? Hypoxia, dilated RV, sinus tachycardia. So what exactly you want to do? What exactly you want to do for this patient and why? So low molecular weight heparin is not the answer. Now, would you like to change your answer? You want to give more thoughts to your process? Yes, Dr. Sandhya. Would you like to comment, Dr. Sandhya? Rabia? Dr. Rabia, would you like to comment on this? Anyone? It's not that very difficult question. Pulmonary
I just
embolism.
Sir,
just
can I?
joined.
Anybody can speak, sir. It is open
Yeah,
platform.
yeah. So this is a desperate situation. Actually, it shows that is a pulmonary embolism is there, and we should act as soon as possible. So we'll
Wonderful.
go for systemic thrombolysis.
Systemic thrombolysis, wonderful. So if I can tell you, sir, I'll change little twist this question. So we got to know this is pulmonary embolism. If I tell you now pulmonary embolism with stable pulmonary embolism and unstable embolism, is there any change in the answer for both? The right options are
Yeah,
same.
in
This or
pulmonary
it will change.
embolism stable, yeah, we from echocardiography, actually the CT pulmonary angiography is the gold standard. So mm, yes, if you have already made a diagnosis, pulmonary embolism is stable,
We did
then
it. We did it. You did it a CT pulmonary angiogram. You did it and it confirmed it is pulmonary embolism. What is the
yeah.
treatment of stable pulmonary embolism confirmed case and what is the treatment of unstable pulmonary embolism confirmed case?
There's the
In
three
unstable
options.
pulmonary embolism, we go for thrombolysis.
Okay, great, wonderful. So option C is here. And what options here? If it is stable, is it the same answer or it's changed? I'm just trying to understand.
So
Option.
it will be changed. It will be changed.
Yeah,
It
in stable, we go for low molecular weight heparin.
yeah.
Wonderful. That's correct. So that is what I want to see. So now let's dissect the question, right? Each and every word is important. So this is dissection. Now I'm doing the real dissection of this question. So correct answer is immediate systemic thrombolysis. So those who
Because
have
unstable.
posted the wrong answer, fix your head. That unstable. This is absolutely unstable. I cannot see any stability in this patient, right? Patient has a dyspnea, patient has a chest pain, patient has a syncope, low blood pressure, high hypoxia, everything is there. If you don't treat, this will die, isn't it? This will die soon, right? So you need to do something immediately. So what important is immediate systemic thrombolysis. You don't have to think something that okay, I will do some blah blah investigation and then he will die. He will die. It's already collapsing, right? So this is a high risk, massive pulmonary embolism defined, right? By what? So shock. What is the definition of shock? I already told you anything less than 90 systolic blood pressure is shock, irrespective of the condition, right? So, and this is there is evidence of right ventricular dilatation as well. Do not delay treatment for imaging in unstable patient. Gold standard line. Systemic thrombolysis, alteplase 100 milligram IV over 2 hours. This is one of the example. If you don't have it, you can use other drug, but for general understanding, this is the story. Let's understand why not the other options, right? We will, our job is not to just get the answer. We'll dissect all five A, B, C, D, E, all options we will dissect. So C is the correct answer, right? Immediate thrombolysis, right? So this is correct answer, but these four are wrong. Why wrong? That is what we need to know and understand. So LMWH too slow for shock, right? Inadequate alone, right? Too slow for shock, right? So you need something which open up the completely the immediately pulmonary vessel. CTPS, CT pulmonary angiogram, useful if the patient is stable. Our patient is not stable. Our patient is unstable. So unstable patient needs treatment first, right? Third thing is direct oral anticoagulant drug for the stable PE, not for the unstable, right? An IVC filter if anticoagulation contraindicated or recurrent PE despite of anticoagulation. In that case, you need to use the IVC filter, especially in our practice, right? We are getting a lot of pulmonary embolism because malignancy. I'm in medical oncology, hematology. So medical oncology, cancer is one of the predisposing factor for hypercoagulable state. So we are getting a lot of pulmonary embolism clinically. They have tachycardia, they have hypoxia, and start, right. So if patient is unstable, will won't waste time giving this and doing investigation. Directly immediate thrombolysis. That's it, right. So this is, and along with that, you need to do all A, B, C, and all. So what is a one line pearl? One line pearl: pulmonary embolism plus shock thrombolysis first. That's it. One line. No delay for any CT scan, no delay for any other things. First do it, otherwise patient will die in front of you. So this is what the thing is. So I think you are pretty much clear. Risk stratification snapshot, high risk massive shock or hypotension thrombolysis, right? And low risk anticoagulation alone like LMWH, low molecular weight heparin, right? I would like to give you the idea about the what is a pulmonary embolism, stable and unstable. This is everybody will see in their ICU one pulmonary embolism in any visit. You go tomorrow your ICU, there are pulmonary embolism. So very common topic, very life threatening, and very important for exam point of view as well. So PE with shock, high risk or massive PE, any of systolic less than 90, need for vasopressor or cardiac arrest presentation, indicates acute right ventricular failure. How do they present? Severe dyspnea, syncope, hypotension, cold calm skin, raised JVP, loud P2, signs of obstructive shock. Right, so that you knows everything, right? So your job is to do the thrombolysis as soon as possible. So shock is equal to thrombolysis unless contraindicated. So you go and read it. What are the contraindication of thrombolysis? It's again common. And P without shock, hemodynamically stable, right? No chest pain, no giddiness, no dyspnea. Blood pressure is like normal, more than 110/20 or within normal limit, or at least more than 90 systolic. Otherwise, fine patient. It is without shock, right? Definition of shock is less than 90 systolic. That is shock. So normal BP or no signs of shock, it is stable. You go and give it the these things, right? So this is what the thing is. So concluding our talk, right? PE with shock, PE without shock. So blood pressure is low in shock, normal in without shock. Mortality is very high, and here the lower. RV failure severe. Here without shock it is mild. First treatment of PE with shock is thrombolysis. Here anticoagulation. Role of CTPA is optional. Optional means you do it, you don't do it. That's fine. There is no compulsion. That is why the word mentioned optional. Most of the people won't do. I never do it in emergency, especially with the shock, and it is required because patient is not in shock, right? You just go and confirm the diagnosis, then you start, right, the treatment. ICU care is absolutely mandatory. It is shock, so you need to do a lot of intervention. And here the selective patient is stable, you may keep them in the ward as well, right? So this is what the thing is. So concluding my talk for this, right, one liner, this is absolutely take home message. If you forget earlier slides, if you remember this slide, your job is done. P plus shock, right? You just need to see less than 90 systolic blood pressure is good enough for shock. So PE plus less than 90 systolic blood pressure is shock, immediate thrombolysis. One liner. This is the answer in the exam. PE without shock, more than 90 systolic, anticoagulation. Stable now, patient is stable now, but it later worsens. Again, you can go for the rescue thrombolysis, right? So this is what the guideline shows in most of the literature. So concluding our talk from where we started is like this is the question scenario. So absolutely unstable patients with pulmonary embolism, classical, absolutely classical, right? So never ever forget, right? So we clarify why not LMWH, why not CTPA, why not oral, why not IVC. So there is no confusion. So check your own score. This is again kind of assessment you need to do. 1 out of 1. Those who given the C answer, it is 1 out of 1. Those who have given the wrong answer, it is 0 out of 1. So let's little understand the new. So I try to involve all subjects questions today as usual. Every time I'm uh, adding all questions in different departments, so you can check your knowledge overall. So pulmonology or emergency is done. Now you come little with the hematology with new tricky things. Some people may not heard of this index called as a Manzer index. So this is the things. 24-year-old woman has 8.5 gram per dl hemoglobin. CBC shows MCV of 68 femtoliter, RBC count of 3.2 million per microliter. What is the Menzer index and most likely diagnosis? So you need to count the Menzer index. You need to know the formula like Parkland formula, weight in kg multiply by 4 multiply by percentage of the bunch. That's it. This is a calculator. So this is a calculator for Menzer index. If you don't know it, then 99% you are wrong. So A12 thalassemia trait, B21 iron deficiency anemia, score is 8. So this index, this suggests the score just for your knowledge, right? Don't get understand. So score is 12. It could be thalassemia. Score is 21. From where this score comes, I'll teach you in next 1 minute. So what do you think, right? So can anyone tell me what is the Menzer index first of all? Without knowing that, it is useless to discuss further, right? So what is a Menzer index? If have you heard of Menzer index in your practice? Menzer index. Dr. Saleh, did you heard of this in your practice? Menzer index? Yes or no? Anyone? Dr. Khadija, did you heard of this Menzer index?
No, sir.
Fair enough. So how you respond to this question? This is not very tricky question. It's a common index. We have it right in a clinical practice, and this is one of the most easiest, most economical, and on the spot tools to diagnose iron deficiency anemia versus hemoglobinopathies. So I think nobody has given me the answer even in the chat box. So I don't know what's going on. So yes, so I think most of the people
So you
doesn't.
explain it, please.
Yes, yes, I will explain you, doctor, everything. Right? So this is the Menzer index, right? So what they are, first of all, understand, right? 24 years, just little keep the scenario in your mind. 24 years old means young woman with 8.5 HB, 68 MCV and 33.2. So I'll teach you from tomorrow onwards. You have to do it everyday practice whenever the CBC, you can see the CBC, they have mentioned. No CBC in the world they did not mention. CBC, absolutely hemoglobin mentioned. CBC, there is automated hematocrit and MCV mentioned. RBC count is mentioned. We need these three things. That's it, right? To calculate the Menzer score. So you go and do it, practice from tomorrow in your patients, in the OPD, IPD, indoor, wherever you see the CBC, do the practice. So three data, hemoglobin is given 8.5, MCV 68, and then. So Menzer index, calculate the Menzer index. How you calculate this index? MCV means mean corpuscular volume, means average size. Normal for your kind knowledge, it is 80 to 100. 80 to 100 femtoliter is normal, right? If less than 80, we called it as a microcytic. Micro means small and cytic means size. So microcytic, small size, more than 100, it is called as a macro. Macro means large and cytic means size. So microcytic less than 80. Number one differential diagnosis is IDA. More than 100 MCV, number one diagnosis is B12 and folate. This is simple, right? We have learned many times, right, in the clinical practice. So they have low MCV. First, you need to know. So could be a microcytic, right? Just for your knowledge, I'm taking you hematology alongside, right? So this is index. Menzer index is what? MCV. So how much is the MCV? 68. How much is the RBC count? 3.2. So 68 divided by 3.2 is equal to 21. So 21 is a Menzer index, right? This is what? Simple, na? Very simple, very simple, right? You need to remember only two things, right? MCV, what is the MCV divided by RBC count, right? You have to calculate mathematics, and this is the final score, right? Say for example, MCV is 100, and this is 4. RBC count 4 million. So 100 divided by 4 means 25 is a Menzer index. Menzer index, right? So that's it. This is what the thing is. So you need to know and understand, right? It is not that complicated the way you think, right? Let's go little further. So Menzer index, now the interpretation, sir, how we interpret the Menzer. If Menzer is 10, what we do? Menzer is 15, Menzer is 20, Menzer is 30, Menzer is 40. How we supposed to interpret? So there is a one-liner interpretation. Menzer index of more than 13, right? More than 13. What's our Menzer is? Our is 21, right? I'm just giving you the recap. Our is 21 as per our scenario. It's our is 21. Let's see. So Menzer index of more than 13 is iron deficiency anemia. How easy? How much it's easy now, right? Because for iron deficiency anemia, you ask the patient to spend a lot of money, right? Serum iron, serum TIBC, serum ferritin, and blah blah, and lot of tests and investigations you are ordering for them, right? Menzer index. So just you need the MCV, you need the RBC count, and that's it. Look at the more than 13, less than 13. More than 13, iron deficiency anemia. Less than 30, thalassemia trait. That's it. Our is 21, clearly more than 13. So our answer is more than 20. It is a iron deficiency anemia. So correct answer is our Menzer score is 21, iron deficiency anemia. Is it there in our options? Let's go and check it out. Right. So our is 21. So our score is 21 as we seen it already. I think you don't have any confusion now. How to calculate? I told you from where this 21 comes. 21 comes 68 divided by 3.2 MCV divided by RBC count is close to 21. So 21 is more than 13. More than 13 is iron deficiency anemia. Less than 13, it is called as a less than 13 is a usually hemoglobinopathy or thalassemia trait. Is that clear to everyone? Yes or no? At least tell me yes or no.
Perfect,
Yes,
sir.
sir. Yes, sir.
Right? Wonderful. So now you can interpret in your OPD tomorrow without doing any iron profile. Any anemia patient comes, go and get the Menzer score. That's it. MCV divided by RBC less than 13, right? Hemoglobinopathy is more than 13 and deficiency. So easy now. So easy now by my sense, right? So that's it. Why not thalassemia trait? Because we have calculated it is 21, right? So calculate value is 12, so it is not there. Our value keep in mind is 21, and less than 8 suggests thalassemia trait, not iron deficiency. Anemia of chronic disease, why not? Menzer score is not 15 and ACD is not classical diagnosis. So anemia of chronic disease cannot be diagnosed by Menzer. So Menzer, where the Menzer actually help, can we diagnose all the anemia with Menzer? Answer is no, especially iron deficiency with hemoglobinopathies or thalassemia. These are the two differential where you can easily differentiate, right, between Menzer, right? So when you are confusion, right, we have many patients, right, 10 years of boy presented with the joint pain and right, he likely sickle or likely thal, you don't know what to do, right? So you do the Menzer score. Okay, Menzer score is more than 13, 99% is a iron deficient. This, then you triage the patient and send the investigations accordingly. If more than 13, go for the iron profile, confirm it, that's it. If it is less than 10, 11, or 13, right, then you ask for the hemoglobin electrophoresis, which diagnose, okay, this is thalassemia trait, this is sickle cell trait, this is sickle cell disease, whatever, blah, blah, blah. Right, so that's it. So concluding my talk, the example last, right, low MCV. If you don't remember anything and just remember the golden line for iron deficiency anemia. Every other woman globally is iron deficiency anemia. So probably we also have iron deficiency. We don't know. So if you have done your CBC in last 2, 3, 4, 6 months, apply this formula. Look at your MCV, right? So low MCV, low RBC, more than 13, right? Menzer, until proved otherwise iron deficiency. Until proved otherwise, it's iron deficiency. That's all. So I think there is no confusion in it. So I'll switching my gear from the first pulmonary embolism, pulmonary emergency to hematology now. Absolutely, completely gear change and different MCQ. Right. So this is what the question is. Third, I want to have at least formalities. Is that clear to all? Yes or no? Yes or no? Wonderful. So most of them
Yes,
there.
sir.
Yes,
Wonderful.
sir.
Thank you very much. Thank you. So by doing the interaction, I also know that you are with me, you are fully conscious, well oriented, and your brain is not outside because today is Sunday, so you have many plans going outside enjoying. So respect my commitment. I am also, I mean, busy guy. So 4-year-old boy present with difficulty getting up from the floor and the frequent fall. On examination, he uses his hands to climb up his thighs while standing. What is the most likely diagnosis? Becker muscular dystrophy, Duchenne muscular dystrophy, limb girdle muscular dystrophy, spinal muscular dystrophy atrophy, sorry. So whatever the answer you give, whatever the answer, A, B, C, D, whatever the answer you give, I will ask you the first question, why? Second question, I will ask you, differentiate all the four things. That is learning, not just A, B, C, D. So now first we jump to the answer because it's important for the exam. So what do you think? What could be the answer? This is kind of neurology.
हाँ मी वही तो
Yes,
रखी हूँ, टेबल पे तो है। अच्छा तो
yes.
थैली में रखा है, ले लो।
Mute your mic, madam. If you
सॉरी
don't,
सॉरी सॉरी।
no problem. Yes, so what is the answer? What is the answer? Open for all. Yes, Khadija. Any comment, Dr. Mifra, Ranmini? We have a lot of doctors, brilliant doctors.
Sir,
Shanas.
I think it's
Yes.
B, Duchenne muscular dystrophy.
Okay, so why you think that this is a Duchenne muscular dystrophy?
Okay, one, it's showing that he's frequently falling, and then he uses his hands to climb up his thighs while standing. That is a particular sign in this case for Duchenne
Okay,
muscular dystrophy, and
wonderful.
it's a 4-year-old boy.
Wonderful, brilliant, wonderful. That is the clue of this question. So that is the answer. Do you know what is a Becker's muscular dystrophy or how you differentiate or Duchenne's? How you differentiate A and B? What
Becker's
is the
muscular dystrophy
presentation in
is
Becker?
milder. It's milder than Duchenne, and it mostly presents further
Fair
late in
enough.
life.
Fair enough. Fair
late
enough. So
late onset.
wonderful, wonderful. So let's dissect. As usual, let's dissect. 4-year boy presented with difficulty getting up from floor and frequent fall, right? And frequent fall. So frequent fall and difficulty getting up from the floor. So he's on floor. When he try to climb or get up, he has difficulty getting up from the floor and he has a frequent fall. What you find on examination is he uses hands to climb up, uses hand to climb up his thighs while standing, right? So this is what is the most likely diagnosis. So 4-year boy, as we seen in symptoms, difficult getting up from the floor, frequent falls. Key signs, uses hands to climb up thighs while standing. It is called go over sign, right? So correct answer is Duchenne's muscular dystrophy. Why early childhood onset? Usually less than 5 years. Our patient has 4 years, fitting the scenario. Favors the Duchenne's over Becker. Grover signs indicate proximal muscle weakness, hip girdle, proximal muscle weakness. Proximal means thigh muscle. Basically, they are thigh muscles, right? So he cannot lift the thigh muscle. He uses hands to climb up thighs while he is standing, right? So this is thigh muscle. So Grover sign indicate this, right? And it is X-linked disorder, right? With the progressive weakness. So this is what the thing is, but why not A, C, and D? Little one-liner explanation. Why not other options are the answer? The Becker's muscular dystrophy, as we seen, is late onset, adolescence, not 4 years of age, young adult, not 4 years of age, and as we seen, it is a milder form, as doctor rightly told. Limb girdle muscular dystrophy, usually later onset, not X-linked. Grovers can occur, but age and classical presentation fits Duchenne's muscular dystrophy. And spinal muscular atrophy, lower motor neuron sign, hypotonia, areflexia, not the Grover signs, not the Grover sign. So concluding our talk, why not the other options? You need to little remember all the key point, high yield. This all are the one liner high yield point, right? So example is what? A young boy less than 5 years with the Gover signs and frequent fall. It is none other than Duchess muscular dystrophy. That's all from my side. So this is neuro. First is pulmonary embolism. Just for revision. Second is a Menzer score. Third is a Duchenne's muscular dystrophy. And now it's all come to the infectious disease. H1N3 virus belongs to, probably don't get me wrong, but you are not happy with me today because all odd questions I am putting in front of you, right? But I want to make your eye opens where we are standing. So H1N3 virus belongs to which virus group? What is it is name? Influenza B, influenza C, influenza A, para-influenza. So what do you think? What is the things and how you differentiate A, B, and C? That is also important. That is also important. So first we need to get the answer. H1N3. And can anyone tell me what stands for H and what stands for N, right? You need to know the full form, no? Like in cancer, there are TNM classification. T means tumor, N means node, and M means metastasis, right? This is tumor size. Like this, what H stands for? What N stands for? Open for all.
Marglutinine.
Sorry? Yeah, you can answer if the same question comes in your screen on your exam. The basic advice is don't keep it blank, put any answer because there is no negative marking. So I'm happy so far. So put any answer. What your heart says, put your answer. Okay, hemophilus. Right. So I got one answer, hemagglutine, that is stands for H. H stands for, right, hemagglutine. Okay, not hemophilus. H stands for hemagglutine. What N stands for? Right. That is all important. Now we are doctors. We need to know. Fine. Okay. Anyone wants to answer this? Try these questions. Volunteer. We are close to now 20 doctors join already. So I can't tell the each and everyone's name, but I mean, you try it. You try it. You must have to try it, right? Because don't take any MCQ lightly. Anything will come in the exam, and we are trying our level best to get you understand the.
Neuraminidase.
Sorry, doctor. Fine. So I did not get any answers. We are a lot of people, so let's go and do it. So the answer is C. If you have something in your mind, answer is influenza A virus. So influenza A virus, H stands for hemagglutinin and ends for neuraminidase. You need to little remember, right? Hema agglutinin and N stands for neuraminidase, right? These are the, right, the H and N are the surface antigen are used only to subtype the influenza A. Our answer is influenza A virus. Why not B and C? Influenza B and C are not classified using H and N antigen. It's a different classification, right? So what they are asking is, right, H1 and 3, right? So this H and N classification, they are the surface antigen are used only to subtype the influenza A subvirus, not for B and C using the H&N antigen. Para-influenza virus belongs to a different group and are not H and N typed. So therefore, H1N3 is influenza A virus. If you are interested, I can take you to the journey of influenza A and B. So let me go very quickly with the important, the point. Influenza A, influenza B, right? So subtype is HXNY, means H1N3, H2N3, H1N1. There is no subtype like H and N, right? So it's a different thing, right? Just for your kind knowledge, right? Another thing is reservoir we need to know human, birds, and pigs, and here the only human to human. Pandemic is easily because it is from bird and pig and human. So here pandemic is very less, like COVID-19, it's a pandemic, right? Global spread. So anything more than three countries at the same time, it is called as a pandemic disease, like COVID-19. Hundreds of countries at the same time, pandemic disease, right? So these are the long classification, but we don't need to go. We are not trying to deal with this all virology and all, but just for basic knowledge, you need to know Pandemic is possible here, it is no, right? Epidemic, yes. Epidemic, yes. Severe, it is more severe, usually milder. So influenza A is more severe than this, can affect all ages. It is more common in children. The example are H1N1, H3N2, H5N1, right? And major pandemic concern, right? So when you have influenza A, it's you need to be very, very careful. So it's not like just the flu, but you need to identify which type of flu it is. So that's all. I'll switch my next questions in front of you. So go and read it against H influenza A B, right? And its logic. So I'm trying to give you the clue, right? Where you feel that you are weaker, right? Because this probably the topics what I'm touching today, and most of the my mock test is trying to give you the clue that okay, because I am a doctor, I also given hundreds of exam and DHA and HAD and MOH and Australian Medical Council and all blah blah. So I know what they ask exactly and where I try to avoid the reading. I know because I pass from the same stage what you are passing. So I'm touching that point which is untouched for you. So next question. A newborn has a unilateral reddish purple patch over the face. You can see the picture coolly and calmly, and that does not blanch. Associated syndrome. So question, it's a spot diagnosis. It's a spot diagnosis. So a newborn has a unilateral reddish purple patch over the face that does not blanch. Associated syndrome. Klippel Trinoyu, neurofibromatosis, Kruger-Weber syndrome, face syndrome. How you differentiate from one from other, that is also important. If your answer is A, I will ask you what is this Klippel syndrome or what you see in Klippel. Yes, anyone, open for all.
The option, sir.
Sorry, sir.
T.
Okay, fine. So I got a couple of answer in the chat box which mentioning the C. Okay, so can you describe me, Sunil sir, what do you mean by Struger-Weber syndrome? What this syndrome is associated with, or it just like unilateral reddish purple patch? Is there any other thing in a Struger-Weber syndrome? Anyone knows? Like, or if your answer is neurofibromatosis, it's okay. But I'm just trying to understand because you answered C. So I want to understand what includes in the Struger-Weber syndrome. Yes, anyone in the house? Yes, please. Yes, Dr. Rabia, did you see such patients in your practice or heard of it or read of it? Dr. Nisha, did you get chance to see this? I think you are a very brilliant lady. So did you come across such patients in your practice or have you heard of something? Yes or no?
Uh, I did not
Sorry,
see, but
madam.
it is generally it will be unilateral and
Okay,
it will be non-blanching.
fair enough. So key clues. Now we knows everything about this. So let's see key clue. Key clue in this question is newborn. Yes, it is newborn. Unilateral reddish purple patch, yes. Does not blanch, yes. So this pictures describe port wine stain, right? And this is the Struger-Weber syndrome. So why port wine stain over the face, especially the trigeminal nerve distribution, is classically associated with the Struger-Weber syndrome. It is due to capillary malformation. Capillaries. Look at this. This is because of some kind of capillary malformation, right? Usually unilateral, non-blanching, right? So it is due to capillary malformation and associated with the leptomeningeal angioma, leptomeningeal in the brain, angioma, right? So tumor of the vessel, that is called angioma. It's a benign condition, but important. Seizures and glaucoma, right? So these are the things is there, right? So what is Klippel syndrome? Port wine stain plus limb hypertrophy plus venous malformation, usually limb, not the face. We have the face, not the limb. So how you differentiate from this another entity Klippel is same rash you can see, port wine stain you can see, but there is a limb hypertrophy plus venous malformation, not the capillary. This is like a because of capillary malformation, This is venous malformation. So venous malformation usually limb, not the face. Our patient is saying it's on the face, not the things, right? Neurofibromatosis, right, is not capholate spot, neurofibroma, not port wine stain, and face syndrome is a large segmental hemangiomas, blanching. Our patient is non-blanching. This is blanching raised, not flat, non-blanching port wine stain, right? That's also we concluded everything. Unilateral non-blanching reddish purple face patch in a newborn, port wine stain, right? It is none other than Stuger-Weber syndrome. That's it. So this is what little new for you, but it is important because they're gonna ask you anything exam, so don't expect lollipop as I told you. Sorry for excuse me because of this all little tricky questions. This is simple questions. We probably face not a single doctor who did not face the transfusion complications, transfusion related complications, transfusion related lot of things. So patients develop fever and chills 30 minutes after starting a transfusion. No hypotension, no hemoglobinuria. What is the most likely diagnosis in this patient? Acute hemolytic transfusion reaction, febrile non-hemolytic transfusion reaction, TRALI, that is called as a transfusion related acute lung injury. I want to know what is TRALI from you guys as well, or is it the anaphylaxis? So what my question is, just not to get the ABCD answer, but my further question would be there. What is the definition of massive blood transfusion? I want to know from the community audience that what, how you define massive. We are many times saying, oh, it's a massive transfusion, hypovolemic shock, hemorrhagic shock, massive transfusion. So exactly what is massive transfusion? Second thing is what is TRALI? I told you transfusion related acute lung injury.
So
How it develop?
transfuse whole blood,
1 minute, let me
massive
finish
trans.
then. Let me finish. So which of the above carries highest mortality? So if you have A, B, C, D, or E, even I can add the options E here as well, right? TACO. One is TRALI and another is TACO. TACO. What do you mean by TACO? Transfusion associated circulatory overload. This is term, absolutely term in the book, right? But probably we forgot or we did not, we overlooked it. So TACO. So E option is TACO. So amongst A, B, C, D, E, which of the above carries highest mortality means highest death? So there are hundreds of questions with the blood transfusion and its complication. But first, let me get the primary questions answered. What is the answer here? Scenario is here. You can read it. Yes, so I got one answer from massive transfusion. I will share with each and everybody. Right. I want the answer. I want the volunteer. I want someone to discuss. Yes, Mifra, what's the answer? Yes, you can unmute your
I
mic.
want to exclude by exclusion, I will exclude anaphylaxis as there is
Wonderful.
no
Wonderful.
hypertension.
Wonderful.
And
So this is brilliant technique, huh? Let me tell you, this is the way you are doing is brilliant technique. So when we are little confused, we need to exclude. Anaphylaxis is not there, right? Because in anaphylaxis, what you see, we'll see it, right? Because you have skin, itching, angioedema, difficulty in breathing, and probably they go into the shock, right? Because of mismatched transfusion or so. They have hypotension. So they are saying no hypotension. There is no, right? There is a hemolysis, and because of hemolysis, there is a hemoglobinuria, isn't it? It is
yeah,
also not there. So this is gone. In general, it is gone. Why not the TRALI transfusion related acute lung injury? So nothing wrong in the lung in this patient.
um,
If
and
at
I
all
will also
TRALI develop?
exclude
Yes. So what? How
hypertension.
you describe Dr. Mufra the TRALI? If you know the things.
Um, Really, I don't know, sir.
Fair enough, no problem. So just remember, this is nothing rocket science. Transfusion related acute lung injury. So what when there is acute lung injury or ARDS, what happens? They have hypoxia. So
Hypoxia,
SpO2 is low. They have high respiratory rate, right?
right?
They may
Low
probably go
oxygen.
into the right. There is a multiple chest infiltrate, right? And this is absolutely after transfusion, blood transfusion. So nothing is there, no? They have not mentioned patient respiratory rate, SpO2, right? Chest examination. And just for your kind knowledge, when they did not mention anything, means it
It's
is
normal.
normal. Not mention means normal. right? Here they have not mentioned SpO2, means SpO2 is normal. If it is low, then they must have mentioned, right? So this is TRALI. Then febrile
I will
non-hemolytic
also,
transfusion reaction.
A also I will exclude, sir, as
A you
that's
excluded,
no.
C you excluded, D excluded. So what is a hemolytic transfusion reaction? How did you get to know that this patient is suffering from acute hemolytic transfusion reaction? How did you get to know? You transfuse patient the blood, right? After half an hour, you need to know whether this patient has an acute hemolytic transfusion reaction or not. How did you get to know? That is what I'm asking you, the clinical question. Or no idea?
There's no signs of hemolysis.
Okay, so let me ask you the second question. What are the signs of hemolysis? Sorry to ask you. This is how we have to do it, na?
Yes.
Yes, fair enough. So you think over it, go and
Hemolysis
read it.
will show jaundice, this hemoglobinuria.
Wonderful, wonderful. So do you think the jaundice will start immediately?
No.
You given the blood transfusion within half an hour, you find. I never seen any patient in my 25 years of hematology practice that somebody has a mismatched transfusion and within half an hour, right? Earlier he was non-jaundic patient and now within half an hour become jaundice. I have not seen. Probably you can share your experience. Yes, please.
No, sir.
Fair enough. Fair enough. No problem. Right. Anybody wants to make any comment? Open for all. This is one of the most common topic and life-saving and important as well. So let me take you to the journey of the time frame of these things, right? When and what happens, right? So you need to remember I'm going to dissect now this MCQ. A patient develops fever and chills 30 minutes after starting transfusion. No hypotension, no hemoglobinuria. Most likely diagnosis is this blah 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 and all other question. We'll discuss each and every. So, what is the clue in the question? Fever and chills, yes. 30 minutes after transfusion, yes. No hypotension, yes. We have no hypotension and no hemoglobin. It is a febrile, non-hemolytic transfusion reaction, right? So, answer here is a B answer. At Dr. Mipra rightly dissected and she excluded other options. So, end of the day, we need to know the correct answer. So, she is right. She secure one good correct MCQ, but she need to know why not this, why not this, why not this. So for that we are discussing little further more. So why this is the correct? Why febrile non-hemolytic? So FNHTR means febrile non-hemolytic transfusion reaction typically present with fever and chills. What our patient has the fever and chills, right? Qualify during or shortly after transfusion. Shortly after transfusion, 30 minutes is short time, right? So shortly after transfusion. So one criteria is matched. Caused by how, right? So this is right. This is Dr. Vipra. You need to know why this happened. We know the answer, right? We have fever and chills. Otherwise, absolutely fine. It is febrile, right? Because fever is there, na? So febrile reaction. So it's a febrile reaction because fever is there and there is no hemolysis, so no non-hemolytic. So febrile non-hemolytic transfusion reaction. Why? This classical two things, fever is plus and within 30 to 60 minute short time, right? It qualifies. Why it happens that we need to know. Caused by recipient, not donors, recipient antibody against donor leukocyte or release of cytokine in the stored blood. Because of these two things, you get a fever. Cause, what is the cause of this febrile non-hemolytic transfusion reaction? The recipient, not the donor, recipient who is receiving the blood, recipient antibody against the leukocyte, donor's leukocyte, or there is a cytokines already there in the stored blood, which is responsible for the hemolytic reaction. That's it. No hemolysis, no hemoglobinuria, right? It is absent. If it is there, then it is hemolytic complication or reaction, not the febrile. The patient is hemodynamically stable. So concluding this all, just fever and chills within 30 minutes, right? That's it. Why not other options? Why not acute hemolytic reaction? Acute hemolytic reaction is would be, right? It could cause hypotension. Our patient has no hypotension, we have seen, right? Patient has a back pain, right? And patient has a hemoglobinuria. Patient has a hemoglobinuria. So they have clear cut mention in the scenario. Our patient does not have hypotension. Our patient does not have hemoglobinuria, right? Trali is a transfusion related acute lung injury caused by acute respiratory distress. Our patient did not have hypoxia. Our patient did not have pulmonary edema. Our patient did not have, right? So this is a worst. This is the most fatal, and that is the reason why we should not judiciously transfuse the blood. So we have to transfuse per the indication. Do not transfuse on the numbers. This is biggest mistake doctors are doing globally. I've seen hundreds and thousands of doctors. Okay, hemoglobin is 6, transfuse. If hemoglobin 7, don't transfuse. So transfusion is not on the number, it is on the symptoms and associated comorbidities. I've treated the patient who has hemoglobin of 4 gram, but she is a 25 years young female, confirmed case of iron deficiency anemia. I supplemented oral and IV iron. Within 3 months, it became from 4 gram to 13 gram. That's it. That's it. No transfusion. When patient is fit, patient is asymptomatic or minimal symptomatic, hemodynamically stable, no cardiorespiratory comorbidities like heart failure or a patient has any cardiac disease, triple vessel disease, no COPD, no pulmonary things, absolutely fine. Young and fit, healthy female with 4-5 HB with confirmed case of iron deficiency, absolutely, it's rather I can say contraindicated. So, so transfusion is not on the number. Fix in your head. Transfusion is not on the number. It's on the symptoms and associated comorbidities, right? So that is very important sentence, right? So you will get to have the feel of this sentence over a period of time as the maturity comes, when to transfuse, when to not, right? So we usually try to avoid the transfusion. For me, being a hematologist, transfusion is the last option for incremental of hemoglobin. I never transfuse until and unless I find out the cause or except there is a dying emergency, right? Patient has a massive crash, road traffic accident, hemoglobin 3 gram, I'll transfuse. I will not become hero until and unless there is no dying emergency of any reason, try to evaluate and then transfuse. Right? Give one thought process to your mind. Is this transfusion is needed? Get the answer from you inside. No, investigate. Do scan, do this workup, you other blood workup, iron deficiency, hemolytic, B12, folate, aplastic, leukemia, lymphoma, multiple myeloma. There are hundreds of list of anemia, right? Try to understand, try to understand. So my take home message for you guys, blood transfusion is not on the number of hemoglobin, it's on the symptoms and associated comorbidities. That's it. So, concluding our talk, patient with the fevers plus chills along within 1 hour of transfusion with stable vital, febrile non-hemolytic transfusion reaction. What you supposed to do in that condition, right? You see, oh, blood transfusion is going, patient is like chills and rigors and a lot of high grade fever, 101. What you supposed to do? Number one is to stop the transfusion in any, not this condition, in anywhere when you feel that that patient has a transfusion reaction, right? Sometimes we are in hurry, forget to stop the transfusion. This is number one. Then whatever you want to do, you do ABC, you call somebody, you announce the code blue, you call the emergency, ship the patient anywhere, everything you can do. But when? After stopping the transfusion. Why? Because that is the main culprit. Transfusion is the culprit. So stop the transfusion. That's it. Then you give the antipyretic. You don't need to be panic. Patient has a fever. So give the treatment of fever. That is antipyretic, paracetamol, acetaminophen. You can rule out. And same time you rule out the hemolysis or sepsis. So how you right send the CBC, right? Before transfusion, say for example, hemoglobin was 7, and within 1 hour it becomes 4 or 5. Then some kind of hemolysis is started, right? And it is fast. Believe me, it is fast, right? And sepsis usually, right? Because that is also concerned bacteria. I mean, blood itself is a big and rich source of the organism. It's a biggest feeder, right? So blood culture, you the best investigation is blood culture, though it won't come immediately, but the investigation blood culture. If you are suspected with the sepsis, give the antibiotic. Don't be hero. Give antibiotic. There is no harm giving the antibiotic. So you can take care of the things. This is the two important thing. Culture. Why you want to do the culture? To know the exact organisms. Staphylococcus, streptococcus, gram negative, E. coli, Klebsiella, Pseudomonas, whatever you want to find out, blood culture will find out. And meanwhile, you send the blood culture state, give the antibiotic to the patient. Right? if you are suspecting with these things, right? So that's all for me for this. And last take home message slide I want to share you, which contains lots of MCQ. So this is our MCQ, right? This is our original MCQ. So this is febrile non-hemolytic. We ruled out everything. We ruled out, and why now we know why the him this febrile reaction happens, because of the antibodies of a recipient, or there is a cytokines in the stored blood, right? And this is one liner. So here 1, 2, 3, 4, 5, 6. This slide contains 7 big MCQ in your exam. Number one MCQ. After long story, they will ask you, what is the universal donor? Which blood group is universal donor? MCQ number one, O negative, universal donor. Second question, AB positive, universal recipient. If the blood transfusion patient comes with the back pain and hemoglobinuria, what's the diagnosis? Acute hemolytic reaction. We have seen it, right? If patient comes with the hypotension, pulmonary edema, hypoxia, increased respiratory rate within 6 hours, it is trally transfusion related. So they will give you long scenario. 35 years male presented with this, hemoglobin is 7. Doctor decided to give blood transfusion. Within 4 hours of blood transfusion, patient presented with acute dyspnea, chest pain, pulmonary edema, crepitation, a lot of infiltrates in the chest. What is the diagnosis? This is trally. Simple. I had given you the scenario as well, right? So for you, trally blood transfusion is given within 6 hours, patient going into the hypotension or shock and pulmonary edema. If you do the bedside chest x-ray, there is a multiple pulmonary infiltrates, increased respiratory rate, hypoxia, everything related bad with the lung. It's trally. Simple and sober. Platelet count less than 10,000, right? You need to give the transfusion of platelet. FFP for bleeding with coagulopathy. So in thrombocytopenia, you don't need to give the FFP. FFP is a fresh frozen plasma, right, which contains clotting factor. So if you have ITP, you don't need to give FFP, right? If you have, say, for example, if you have low platelet because of dengue, you don't need to give FFP. FFP is for factor, not for the platelet. That is what I'm trying to clarify. So FFP for bleeding with coagulopathy, you give, right? And one is massive transfusion. So again, I asked you the earlier, what is the definition of massive transfusion? So let me give you the complete crystal clear idea about the massive transfusion. So massive transfusion is defined as one of the following, not only one, more than 10 units, one of the following. What are the one of the following is? Number one, more than 10 units of pack red blood cell within 24 hours. So somebody is transfusing within 24 hours 10 units of blood cell or red blood cell, right? Then it is a massive transfusion, right? Or more than 4 units of red blood cell in 1 hour, within 1 hour, massive road traffic accident, absolutely bleeding like anything from all the sides, multiple site. You had started the blood and given more than 4 units within 1 hour. Again, it is a massive transfusion. More than 50% of the total blood volume replaced within 3 hours. It is also massive transfusion. And more than 1 unit of red blood cell every 5 to 10 minutes for ongoing hemorrhage. That is also massive transfusion. So there are four definitions we now need to know. What is the massive blood transfusion? So the simplest is like more than 10 units in 24 hours. But somebody did not get within 24 hours 10 units, but somebody has a massive blood hemorrhage, ongoing hemorrhage, right? And you are giving the blood transfusion in 5 to 10 minutes, like a bolus, it is massive transfusion, right? So why this matters is massive transfusion causes the dilutional coagulopathy, right? Factors are diluted, so they are bleeding more. Hypocalcemia can happen, hypothermia can happen, acidosis can also happen, right? So massive transfusion is like transfusion of more than 10 units of PRBC in 24 hours or 4 unit in 1 hour. So that is the like simplest definition we know. So that's it. And last slide for the transfusion, because they are asking a lot of questions and it is absolutely a high yield topic for clinic, because we are every day we are dealing with the patients and ordering the transfusion, give 1 unit, 2 unit, 4 unit, right? So trolley, as we see, what is the which condition 1, 2, 3, 4, 5, which has the highest mortality or death? Highest mortality is the trolley. So I'm always worried about trolley when I'm ordering or when I'm giving the instructions to my resident. Okay, doctor, you go and right transfuse 2 unit of blood, because trolley, right? You have all respiratory hypoxia, hypotension, non-cardiogenic edema or pulmonary edema, and highest mortality means death. So don't transfuse irrationally. You need to justify, you need to convince yourself before transfusion, right? So blood is life, right? So don't use it randomly only on the just number. Transfusion indication is not on the number in any guideline except emergency. They are on the symptoms and associated comorbidities. Keep in mind. Acute hemolytic reaction, also high mortality. Patient presented with the back pain and hemoglobin, urea, and DIC, as we discussed. TACO, transfusion associated circulatory overload. So patient is in cardiac failure and your hemoglobin is 5. You are ordering give 3 unit of blood transfusion, 4 unit of. So there is a circulatory overload, heart failure. It is moderate risk, hypertension and fluid overload, eventually pulmonary edema and probably death. Right. So TACO is also important. TACO stands for transfusion associated circulatory overload, like transfusion related acute lung injury. Anaphylaxis, moderate risk, bronchospasm, hypotension, right? So that's it. And febrile non-hemolytic transfusion reaction, which is our answer. It carries one of the lowest mortality or almost no mortality, presented with fevers and chills only within 30 to 60 minutes. No signs of sepsis, no signs of hemolysis, no signs of circulatory overload, and no signs of pulmonary symptoms. It is simple febrile hemolytic reaction. Is that clear to everyone? At least you need to tell me yes or no. At least tell me yes or no.
Yes, sir.
Yes, sir.
Yes, sir. Yes, sir.
Wonderful. Thank you very much.
Yes, sir.
That's it. So that's it from my side for this thing. So we answered all questions. What is the definition of massive transfusion? Right? At least 10 units in 24 hours or in 1 hour. This 4 unit. That's it. Simple. Trolley we know now, which carries the highest mortality we know now. Right? So highest is with the trolley. Right? So everything we have seen it in this. So now just keep and apply this knowledge to your practice from tomorrow onwards. Right? It is very important. Let's jump to the next question. 70-year-old man with a pneumonia present with respiratory rate of 32 per minute, BP is 180 per 70, normal mental status, urea is 6 millimole per liter. What is curve 65? It's like a Menzer score, right? We see in second MCQ Menzer score. So we calculated MCV divided by RBC. We got some score. Here you need to know the score. You need to know what is CURB. First of all, you can anyone volunteer tell me what is curve 65? Number one, right? Number one, full form of curve 65. Lot of questions, 100 and questions with this, and it is one of the most commonest thing. What you can see in the ICU is pulmonary embolism for sure. You can see the anemia and blood transfusion for sure every day. I'm not talking occasionally, every day. Most common condition, pneumonia, every day you see in your practice. This is related with pneumonia. So what is the curve 65? Why we want to make a curve 65 score? What is the emergency making this curve 65 score? What is the clinical significance? How we interpret? What is the score? Anyone volunteer?
Uh,
Confusion.
stands for C for confusion, U
Okay,
for
C for
leukemia,
confusion. I'm writing down, doctor. I'm not in hurry. Confusion. U for
Yes.
uremia,
uremia.
R for
R for
respiratory rate,
respiratory rate, and B for
blood pressure,
and 65 for
age 65.
age. So we are
Age.
now completely clear that what curve 65 stands for. Now calculate the score. That is a second point for you. Now you calculate, doctor. Right? If confusion is present, just a clinical clue to you. If it is present, the score is 1. If it is absent, score is 0. If uremia is present, score is 1. If absent, 0. Respiratory rate is more than 30, it is 1. Less than 30, 0. Blood pressure less than right 90 systolic, 1. Normal blood pressure, score 0. If more than 65, score 1. If less than 65, 0. Now I'd given you complete transparent clear cut view. Now you calculate how much score I'll put for confusion, 0 or 1. This is a result. Whatever you tell me, I will put it here and I'll calculate the score.
Sir, 3.
Yes, sir.
Sir,
Two,
3.
Zero or
Answer is 3. C3.
no problem, but I want to calculate. Confusion, doctor,
0
you
for
told me.
1 for A.
One minute, doctor. I'm not in hurry. Confusion, what I'm supposed to post it here? Zero or one?
0.
Zero.
zero.
0.
Because there are few people they don't know. I want to teach each and everybody. So confusion is zero. Why zero? Let me tell to the audience because
Normal.
normal mental
Because no.
status means she is not in confusion. If they are saying
Hmm.
patient is confused, I will put it
Hmm.
one. No confusion, mental status score zero. Wonderful. Uremia. What is the definition of uremia in cup 65? How much is
It
the
should be
millimole
more
per
than
liter?
7.
More than 7 means 1. Less
It's
than
more
Yeah.
than
7 is
7.
0.
You,
So 0.
So
0.
this is 0. Just for the
0.
newcomers, those who don't know, if the uremia they say 7.5 millimole per liter, so anything more than 7 is 1, anything less than 7 is 0. So here 0. Respiratory rate, how much is the respiratory rate? More than 30 is
32.
right 1. So this is
And
32, right? So
One.
this is
It's
1
1.
1. Blood pressure is how much? Hypotension, this is
Zero.
normal.
normal.
So normal 0. Normal
0.
if 0, and last but not the least 65 age, patient has a 70 age, so anything
1.
less than 65 is 0, anything more than 65 is 1. So I'm putting it here, so I'm calculating all five. CURB 65 score is 2, so
2.
answer is score is 2. Look at the answer. What is the answer? This is the correct answer. That's it. Is that clear to everyone? At
That's
least tell me
perfect.
yes or no.
Yes.
Yes, sir.
Wonderful,
Yes, sir.
brilliant. Now let me ask you, right? Any volunteers, zero, one, right? If you have five score maximum, the score could be like this, right? If somebody has all things, confusion is there, uremia is 10, respiratory rate is 35, blood pressure is 90, and age is 70. So everything has 1, 1, 1, 1, 1, maximum five score. So what to do with the five score? What to do with the zero score, what to do with the one score, what to do with the two score, likewise three and four. So, is there any importance of knowing this score 0 to 5? What is the importance in clinical? Sir, what is the
Yes,
practical
yes,
implication
sir.
of this? Yes, please. So, what is the practical implication?
Sir,
Anybody can.
to decide the station of admission.
Okay, so decide
Is
the
the either
station of admission.
Severity of the disease. Yes.
yeah.
Okay, so let me ask you, Dr. Rabia, if you have a
Hmm.
2, score 2, what you do? If you have score 4, what you do?
Patient can
If you have
add.
score 5, what you do? Let her finish first, Dr. Rabia. Then I'll come to you, doctor. Yes.
Hmm.
Now tell me, whatever
So,
you tell me, I'll write down.
so it is score to who can admit it and in ward.
Okay, I will add. So you want to admit in the ward this patient. Okay. 4, where you want to admit this patient?
High density unit.
High definition unit. Okay, where you want to admit, and here where you want to admit? 5,
ICU. ICU.
ICU.
Definite ICU.
ICU. And if the score is 1,
OPD.
So ward.
O-
Again ward.
OPD.
Again, if 70 years with OPD. Okay.
If the score is 0, then
Send home.
right.
Bye bye.
Send home.
So this is the, so let me tell you, zero score is the best score, and 5 is the worst score. Right? So when patient, any pneumonia patient and curve 65, especially this is used for community acquired pneumonia, CAP, community acquired pneumonia. So if you calculate for any community acquired pneumonia curve 65, right? If 0 is the best score and 15 is 5 is the worst score, like Glasgow comma scale, like GCS scale, where there is no 0, there is a 3 to 15. 15 is the best score, 3 is the worst score. Here likewise, 0 is the best score, 5 is the worst score, right? So that decide how the severe pneumonia is, and depends on that you decide where to, number one, right? Number one, you need to decide whether to admit or not admit. This is number one, right? Are you getting me? Admit or not admit? Are you getting me? At least tell me yes or no.
Yes.
Yes, sir. Yes, sir.
Now, second question, admit, then where to admit? Should I admit, sir, in the ward? Should I, sir, admit into the ICU? Or where I supposed to admit this patient? That is second question. No admit means outpatient, outpatient, OPD, outpatient department. OPD, no admit. You don't need it. Zero, one, you don't need to, right? Just monitor them, right? So this is a clinical implication. It reduces the burden to the hospital as well. You can't, oh, pneumonia score zero, admit him. You don't need admission. That's it, right? So this is what the complete crystal clear idea as we calculated rightly, but once again the revision absolutely high yield question. Our score was 2 because age is more than 65. That is why we counted one score, and we have a respiratory rate of more than 30. That is why we counted one score. So our score was 2. This is how it comes, right? So C means confusion. Our patient has normal status, score 0. Urea more than 7. Our patient has 6, so 0. Respiratory rate should be more than 30, right? Our patient has 32, that is why one score, right? Less than 90 systolic, our patient is normal, so score 0. Age more than 65, our patient is 70, so 1. So 0 plus 0 plus 1 plus 0 plus 1, total, if you calculate 2, that is why the answer is 2. So total curve 65 is 2. Now we'll see what is the importance of 2, where we supposed to admit or not admit or make it in the ICU or outpatient department. So clinical interpretation of CUP 65 moderate severity pneumonia, management hospital admission, general ward usually, right? So this is what the thing is. So now this is general idea which you need to know. And once you calculate for your patient, you can go according to this chart. Assess the severity of pneumonia. Stratify patients is in low, medium, or high risk. So 0 and 1, as we seen it, it is in the low risk. 0 and 1 is in the low risk, right? So 0 and 1 is in the low risk severity, low risk or mild, right? What is the death, right? In mild case, what is the death? Less than 3%. Means 97% plus patient are absolutely fine. This is not 3%, even less than 3%. So it could be 98, 99, right? So there is extremely rare chances of mortality. So this patient you can do it on an outpatient, right? 0 and 1. Then 2 alone, moderate risk, right? Moderate risk, mortality. So if you are going the score 0 to 1, 2, 3, 4, see the mortality is increased. Here 3% people dying, here 9% dying, and here can you see the literature up to 40% maximum, up to 40%. So here if you can keep 3, 4, 10 times mortality is high. If the number change, if somebody say 1, 3% mortality. If somebody is saying 3, 40% mortality. See, 3 or equal to 3. So how the mortality varies, right? As the score increases. So bad the score, higher the score, bad the prognosis, higher the mortality. So this is very important for us. And that is why we calculated this CUP 65 score. So less than 1, 0, 1 means mild. Again, the same thing, right? The criteria will not change. Mild, moderate, severe. So this is mild, right? Again, refresh 3% mortality, very less outpatient. 2% moderate, mortality is 9-10%. You need to admit it. 10% mortality is very high. And more than 3, severe cases up to 40%, up to 40%, right? Severe community acquired ICU assessment. So here outpatient, here inpatients can be in the ward or can be in the high unit, depends on the clinical condition. This is the surrogate marker, but you cannot allow this patient to go home. Okay, don't worry, you go home. Never ever tell us. So remember, anything more than 10 to admit. Simple. Anything more than 2, cap, admit, observe. If he is fine, no problem. After 48, 72 hours, reevaluate. Again, reevaluate the CUP 65 after 72 hours, right? If it is going from 2 to 0 or 2 to 1, improving, or 2 to 0, then you think of discharge the patient. But you cannot advise that, okay, fine, you are absolutely walking, talking, go home. Anything more than 1 or 2 plus is admission. That's it from my side, right? So this is what the bottom line is for the CUP 65, right? Also, you can give the antibiotic and rest other things. So I'm not going much in detail of this. And high yield one liner exam answer, CUP 65 is important to assess the severity. What do you mean by severity? Mild, moderate, severe. 0, 1 is mild, 2 is moderate, 3 plus is severe. So each and every sentence is important. Assess severity, number 1. Number 2, predict mortality. Mild 3%, moderate 10%, severe 40%. and decide the site of the management, OPD, general ward, ICU. That's it. So not the CUP 65 will decide the admission. It decides the severity, it decides the mortality, and it decides the place of the admission to the patient in the hospital. Is that clear to everyone? Yes or no?
Yes, sir.
Yes, sir.
Yes, sir.
Wonderful. So this is again a last slide for this pneumonia related things. So one liner MCQ call, dry cough plus infiltrates, atypical, dry cough, usually typical as a productive cough, dry cough, atypical. Lobar consolidation plus productive cough, it is typical. So you need to know what is the difference between typical and atypical. I'll ask you each and everybody in the next class. No response to penicillin, think of atypical, and hyponatremia is classical for Legionella. These four are the one-liner MCQ near exam. They ask you long scenario and they say patient develop hyponatremia. What could be the organism? Legionella. That's it. So typical is lobar, right? Lobe is involved, cough is there, productive. They have yellow sputum, that is called productive. If they have no sputum at all, it is dry cough, and they usually typical start sudden. Atypical is interstitial, dry, and gradual. The biggest example of atypical is COVID-19, right? So that's it. And if you wish, I can take one more MCQ if you allow
Yes,
me.
sir, please. Yes, sir, please. Yes,
Wonderful. So,
please.
last questions for today. Which bariatric surgery has the highest risk of nutritional deficiency? So, someone has to
Okay.
explain me what is sir bariatric surgery, because I'm very particular in sentence, right? And that is very important. So, what do you mean by bariatric surgery? What is the concept in your mind for bariatric surgery? Number one question before ABCD. Second is highest risk of nutritional deficiency. So by doing which of the following surgery or barrier, all are bariatric surgery, A, B, C, D, we'll see it in detail. So which bariatric surgery has the highest risk of nutritional deficiency? Recently asked question in exam. So you need to think over it and you need to tell me. Is it sleeve gastrectomy? Is it adjustable gastric band? It is ROX and Y gastric bypass, or it is biliopancreatic diversion. So what is this all? Probably people have like little new questions for you, but recently asked the question in exam, so I little bit formatted it and try to present in front of you, so you get the idea about this as well. You need to solve few toxic questions which improves your score. So our goal is not to get 60% cut to cut in DHA, the MOH or OMSB. Our goal is to get 90%. So if you fall short, you get at least 80, you get at least 70, 100% pass. Our goal is not 60. Our goal, if your goal is 60, then you don't need my coaching. Believe me. If your goal is 19, then you come and get it. And I'm doing it all. I mean, humanitarian services I'm trying to do it, not asking single penny. So the motivation of mine is sky high. You need to show the same motivation level for every time, because this doesn't this PowerPoint for you it's like listening 90 minutes. For me, I spend my whole week to prepare this quality content. Anyway, so anybody wants to try this bariatric surgery has the highest risk of deficiency nutritional. So by doing which surgery the patient is at highest risk of developing iron B12 folate deficiency, that is nutritional deficiency. Okay, so probably I think I did not get any answer for these questions. Anybody wants to try? I'll give you
Sir,
one
I
more
think
second.
C. I think
Sir, is,
C.
is the gastric bypass surgery?
Right. So that is also wrong. So correct answer is D, biliopancreatic diversion. For your kind knowledge, let's dissect. Let's dissect. Right. So dissection brings clarity. Biliopancreatic diversion. Right. Let me let me give you first this brilliant chart. It's invaluable chart. Difficult to get this chart without journal. So I try to open up the journal and I try to get it for you. So these all are the bariatric surgery. These all are the bariatric surgery procedure, and it's all one high yield comparison chart. So adjustable gastric banding, it's a bariatric surgery. Sleeve gastrectomy, this bariatric surgery, Rooks and Y gastric bypass, biliopancreatic with duodenal switch, and jejunoileal bypass. These all are right. In short, they are cut. The they are cut. They are trying to do the surgery by which you can reduce your weight. Bariatric surgery is a weight reduction surgery. So any surgery you do for weight reduction, it is called as a bariatric surgery. Simple and sober, right? So the answer is biliopancreatic diversion. It is a type of malabsorptive surgery. Large gastric resection means resection means completely larger part of stomach is removed, right? And there is an extensive bowel bypass. What is the advantage of this in terms of weight loss? Very high weight loss. So if somebody has a like 150 kg weight, by doing this surgery, he can become a 80 kg, half the weight. Handsome boy, he can become from obese boy, right? So this is the highest, very, very high. This and this are the very high doing surgery. If somebody wants to reduce the weight fast, these are the two options for surgery, right? But what is another risk of this surgery? So weight loss is excellent, but same time very high risk of what? Nutritional deficiency. Very high risk. Highest nutritional deficiency risk associated with biliopancreatic, right? So remember this. Another very frequently done world over, the advantage and disadvantage. Second is a sleeve gastrectomy. 70 to 80% of the stomach is removed. 70 to 80% volume. So this is your esophagus and this is stomach. So 80% of your stomach is removed. Just you have small 20% stomach remaining, right? This is removed completely 80%. That is why called as a sleeve gastrectomy. Gastric means stomach and tommy means remove. So sleeve gastrectomy, name is sleeve gastric. It's sleeve like sleeve gastrectomy. 70 to 80% of stomach removed. Weight loss is moderate to high. Nutritional deficiency risk is low. So this is people are going for this as well, because when you remove the stomach 80%, your capacity is gone, your appetite is gone, your hunger is gone, right? So obviously you will lose the weight, and it is most commonly performed surgery globally, not in Western, Eastern, Middle East, globally, right? So that's it. This is what I mean. You don't need to remember lots of things about this. You are not going to go for bariatric surgery exam, but you need to know which bariatric surgery, right, has the highest advantage of weight loss, which is the commonly done, what's the nutritional deficiency. And this patient usually taking, I have few patients, not my patients, but they are coming for, they develop anemia, right? This patient develop anemia because they have iron B12 deficiency. They comes to us, right, post bariatric surgery for reference for pancytopenia, and we give them the lifelong supplementation of iron B12 because it's all gone, right? So what is the crux of the talk? Common deficiency by procedure. Sleeve gastrectomy, iron and B12 less common. Iron B12. Why? Because you need to know iron, B12 and folic acid absorbed from where? Absorbed from where? Can anyone tell me the site of the absorption of B12? Anybody know B12?
Payas
Site from
patches.
where?
Intestine.
Payas patches. Abriaria.
Intestine, madam, broad term. I will tell you duodenum, jejunum, ileum, cecum, ileocecal junction. This is all intestine. Now tell me,
Proximal ileum.
ileum. Absolutely correct answer. So when you do the sleeve gastrectomy, you are removing the stomach, not the ileum. And that is why iron and B12 are less common. This is common, but you need to know iron is, so your homework is where the exactly iron absorbed, where the B12 absorbed, where the folate acid absorbed from the intestine. One we have discussed B12 from ileum. Rest two is your homework. Important question. So sleeve gastrectomy less common. This RYGB is also BPD and duodenal vitamin A, D, E, K. These are the all fat soluble vitamins along with protein and calcium. So highest deficiency of vitamin or nutritional deficiency is with the biliopancreatic diversion, that is stands for BPD, biliopancreatic diversion. Quick examples, the last 1 more minute with me. Most common surgery, if they ask you in the exam, which is the most highest performing surgery globally for bariatric patients? Sleeve gastrectomy. 80 to 90% of stomach is removed. Weight loss is excellent with reduced chances of nutritional deficiency. Highest nutritional deficiency, answer change. Biliopancreatic diversion, BPD. Dumping syndrome. What do you mean by dumping syndrome? You go and tell me to in the next class. Rooks and Y gastric bypass. Least deficiency, adjustable gastric bending, where you are not removing anything, you are just bending the stomach. Least deficiency. And best long-term weight loss. Best long-term weight loss in which is the highest one? The advantage BPD, biliopancreatic diversion. So that's all from my side, and thank you very much for all listening me coolly and calmly for more than 90 minutes now, I think so. So before I end up my session, I would be glad, happy, and thankful for your quick feedback. How did you enjoy it? I enjoyed tremendously this class, discussing all new MCQs. So, how is your experience? Just spend 1 more 2 3 minutes if you don't mind. Yes, please. Anyone? If you feel you learned, you share the experience. If you feel you don't learn anything, everything is known to you, then probably it's not fascinating for
So
you this class.
as today's questions are quite difficult, but we learned a lot.
I told you, Dr. Rabia, every time don't expect in the exam the lollipop question. You understand? You need to be prepared. Next
Yeah, you
Sunday,
are
it
right.
would be all different.
Yes.
You will learn everything. I'm now 360-degree changing the pattern, right? I don't want to teach you only lollipop. Once you are habitual with it, if you see such, oh, bariatric surgery, you never heard of it. You are confused. Our bottom line goal is
And
to pass the exam in first go. In first go. That is the bottom line. And
Yeah.
for that, we need to prepare everything,
Inshallah, inshallah.
right? We need to get out of our comfort zone. But I also would like to rest every Sunday. I never skip any Sunday. Even though I'm so busy, I never skip any Sunday. I never compromise my quality of the education, whether 10 people are there or 100,000 people are there. I am the same flow. So you need to prepare well. That is what my take home message, right? Not only the just lollipop questions. Yes, anyone else?
yeah, sir, it was
Comment?
an excellent lecture.
Yes,
And
Anisha.
I learned many things, many new things,
Wonderful.
especially
Brilliant.
the question about the blood transfusion and bariatric surgery and other topics also, all new, and we learned a lot. And
Wonderful.
thank you very much for this.
Wonderful. Thank you very much, madam, for your kind feedback. Any other? Anyone on? Mifra, how was your learnings?
It
Shahnaz, how
was,
was your
I also learned a lot of new things, and your
wonderful?
lectures are really motivating to study further. And though
Wonderful.
it's little questions, but you made us explore into many more questions in between. It is
Yes,
really motivating, I should say,
wonderful. Thank
making
you for
us
your kind.
study more.
Yeah, so try to do it in that way. Our job is not just to conclude A, okay, A is answer. You need to know
Yeah.
why not B, why not C. This is kind of differential diagnosis. If you give me 5 grams of HB, I'll differentiate. Sir, this is iron deficiency. This is B12. This is like anemia of chronic disease. This is hemolytic anemia. This is bone marrow related leukemia. I have clarity in my mind how I supposed to differentiate. That makes the learning. That is what you need to do, right? Otherwise, I mean, everything is in the book. Why you didn't need my coaching or why you need my lectures? Everything is in book. Na? I did not bring anything from outside. Na? I little make it fine adjustment and presented to you in a flavored way, right? But it's important. Anyone last but not the least, anyone wants to comment? I would be glad.
I would be liking to comment on that you have a gift of public speaking. And your presence, I mean, whenever you speak, it feels so comforting that, we can inculcate those things in our minds. And you're really, really, really a blessed person. We are also blessed to have you, sir.
I'm also blessed to have a good people around me who can listen me coolly and calmly.
Definitely, definitely.
Wonderful. So
Thank
thank
you.
you very much. Yes, please.
Thank you,
Anyone?
sir.
Thank you very much. So
Thank you
just
very
stay
much, sir.
tuned
Thank you.
and prepare well, prepare well, prepare well, prepare well. That's it. That is what my take home message. Your success is my success. So keep in mind. Thank you very much and enjoy your Sunday.
Thank you so much, sir. Thank you, sir.
You are welcome, sir. Take care.